This video is going to look at the reliability and validity when diagnosing and classifying schizophrenia. So if we have a look at the specification, there's key things you must know in this topic. You've got to know about the reliability and validity of classifying and diagnosing schizophrenia, the issue of comorbidity, cultural bias, gender bias, and also system overlap. So there's a lot of little topics you need to know when we're diagnosing and classifying schizophrenia. The first thing we're going to look at is the reliability, and we're just going to recap on what reliability is. So this is when the diagnosis must be repeatable. Can we repeat it, get the same results? So we're going to look at test-retest reliability, which is can we draw the same conclusion at different times? So if we carry the test out once and we carry it out again, can we get the same results? And also inter-rater reliability. So this is when, if we get two different clinicians, will they both reach the same conclusion? And this is usually measured by something called a kappa score. Okay, so do two clinicians both get the same diagnosis if they were to assess the same individual? So we're going to look at a few studies that investigated inter-rater reliability. And the first one looked at two psychiatrists. Okay, and these psychiatrists were asked to assess 100 patients using the DSM and the ICD. And if you remember back to the last video, these are the two systems that we use. Americans use the DSM to assess schizophrenia, and Europe uses the ICD. So two psychiatrists assessing 100 patients. And what they found was that it had poor inter-rater reliability. For example, one psychiatrist diagnosed 26 patients using the DSM with schizophrenia and 44 patients when he was using the ICD to diagnose schizophrenia. So basically it shows us that schizophrenia is either underdiagnosed or overdiagnosed depending on which system we're using. And Rieger conducted another study looking at the inter-rater reliability. And I mentioned a little bit earlier about this kappa score. And usually for a kappa score for inter-rater reliability, any score of 0.7 or above is considered good. So we get the two scores from the two psychiatrists, we correlate their scores. If they're similar, we get good inter-rater reliability. And 0.7 is generally considered a good score when we're correlating. But he found that for the DSM, that the kappa score was only 0.46. So again, it shows us that inter-rater reliability is a key weakness of this, because it can be either under or over diagnosed depending on which system we're using, and also 0.46 is a pretty low score on the kappa scoring to state that this is an effective diagnosis tool. Comorbidity refers to the extent that two or more conditions can coexist or co-occur in an individual. And the major issue with comorbidity is that if two or more conditions can coexist, then it calls into question the validity of their diagnosis, because they might actually be one condition. And with schizophrenia, the main issue is that there's a lot of comorbidities with schizophrenia. Schizophrenics can often have OCD, depression, so it might be the fact that these things are actually one condition rather than being separate conditions. And that's going to have big implications when it comes to administering and advising patients on which type of treatment to get. So Buckley looked at the issue of comorbidity and found that depression occurs in 50% of schizophrenic patients. And there's two possible sort of conclusions we can draw from this. One, maybe we're just very bad at telling the difference between the two different conditions. Or two, if they're similar, and if 50% of patients actually have depression and schizophrenia, maybe they could be seen as a single condition. So overall, this issue of comorbidity and the fact that schizophrenia can exist with other disorders paints a very confusing picture, which is a major limitation when we're diagnosing schizophrenia. So another limitation when diagnosing schizophrenia is the issue of gender bias. And this is where diagnosis becomes dependent on the gender of the patient. And there's two real places where we see gender bias. One, we've either got gender bias criteria for diagnosing schizophrenia, or the clinicians and psychiatrists have biased judgments based on gender stereotypes. So men are more likely to develop schizophrenia, so I'm more likely to diagnose a male with it than a female. And Powell conducted a study on 290 male and female psychiatrists. And each psychiatrist was given two case studies. Okay, patient A, patient B. And when the patient was described as a male, 56% of those patients were diagnosed as schizophrenic. But when that person was described as a female, only 20% of them got diagnosed. So the exact same cases, the exact same behaviours written down, but 50% or 56% when they were described as a male, and 20% were diagnosed when they were described as a female. So there's clearly some gender bias there. However, this evidence of gender bias wasn't present when you looked at the results of the female psychiatrists. So overall, it shows us the gender of the patient clearly is a factor in the diagnosis of schizophrenia, and also the gender of the psychiatrist is. Male psychiatrists are far more likely to diagnose someone as schizophrenic than a female psychiatrist. In addition to that, males are far more likely to be diagnosed than females. So, Longnecker conducted another study and found that since 1980, men are far more often diagnosed than women with schizophrenia. And he came up with a few explanations for this. He said, one, maybe males are more genetically vulnerable. Okay, so there's a biological reason potentially. Or there is a case for gender bias. The fact that women function far more better than males with the disorder. They're more likely to go to work. They're more likely to stay on and prolong with education. They're more likely to have successful relationships. And this bias here, this fact might actually bias practitioners, bias psychiatrists to underdiagnose schizophrenia in women, simply because they can deal with the condition far better than males. So therefore they don't come across as showing the characteristics that are associated with schizophrenia. So when we're looking at diagnosing schizophrenia, we've also got an issue of cultural bias, and the fact that African American and people with Caribbean origin are several times more likely to be diagnosed with the disorder than white people. And the interesting thing here is that if you look at schizophrenia rates in Africa and in the West Indies, they're not high. So it can't be genetic vulnerability. So people in America who are of African American descent are far more likely to be diagnosed with schizophrenia. But Africans don't have high rates of schizophrenia. So it can't be genetic vulnerability. There must be something else to explain why African Americans, Caribbeans are more likely to be diagnosed with the disorder. And some people have suggested that maybe it's the fact positive symptoms, so remember things like hallucinations, hearing voices, are more acceptable in African cultures. So when they're reported to a British or an American psychiatrist in a different culture, then that psychiatrist sees that as bizarre and irrational and diagnoses someone with schizophrenia. Whereas in their own culture, hearing voices might be considered completely normal. Other researchers have gone as far to say that white psychiatrists just don't trust the honesty of black people during the diagnosis. So, quite controversial, but some psychologists have come out and said that when white psychiatrists are diagnosing black patients, they simply don't trust them to tell the truth, or don't trust what they're saying. So therefore, diagnose them with schizophrenia for that particular reason. So, we've looked at this issue of cultural bias and found that in different countries and in different cultures, we get to see differences in diagnosis. So how he studied this was he got 200 US and UK psychiatrists and gave them a description of a patient. So the 200 American and UK psychiatrists were given the exact same description of a patient. And he found that 69% of US psychiatrists diagnosed that person with schizophrenia, and only 2% of UK psychiatrists did. So clearly the culture that we're brought up in and the country that we're brought up in clearly determines whether schizophrenia is going to be diagnosed or not. Another limitation of diagnosing schizophrenia is the issue of system overlap. And this is where we get considerable overlap between the symptoms of schizophrenia and other symptoms. For example, if you look at schizophrenia and bipolar disorder, they both have positive symptoms, so both of them include delusions, and they both have negative symptoms, this evolution or this lack of motivation. So both of these different mental disorders have an overlap of symptoms. And the issue here really is that it calls into the validity of the diagnosis and classification of schizophrenia. So if we use different symptoms, if we gave a psychiatrist or psychiatrists different systems to measure schizophrenia, people that use the ICD might diagnose the patient with schizophrenia. Someone using the DSM might diagnose them with bipolar disorder. So it wouldn't really be that surprising if that occurred, because you've got delusions, you've got evolution, you've got this overlap of symptoms that occur. Right, the last thing we're going to look at is the fact that there is a lack of objective tests for schizophrenia. And this is a really big weakness because there's no biological test to determine whether someone is schizophrenic. We can't take a blood test, you can't do a brain scan necessarily to say this person has schizophrenia. Assessment is done through the clinical interviews. So to diagnose someone, it's got to be done through a clinical interview with the patient. And this leads to real big problems because a lot of people have argued that potentially if you can't test schizophrenia physically and you can't diagnose them physically, then perhaps it's not a disorder at all. So we've had a look at all these different weaknesses, and each of those key terms we mentioned at the start for the specification, you could get a short question on. This could all be put into one big essay, or you could get a short question on just comorbidity, or just system overlap, or just reliability. So make sure you know a little bit about all those words at the start of the video.